Here's a riddle that runs the whole system. A hospital loses money on most of the patients who walk through its doors. It gets paid less than its costs for everyone on Medicare and Medicaid, which is a huge share of its patients. And yet somehow the lights stay on. The cranes keep building new towers, and executives earn millions. So how does a hospital actually make money? The answer is one of the most important and least understood mechanisms in American healthcare. And once you see it, a dozen other mysteries, from your surprise facility fee to why hospitals keep merging, suddenly make sense. Start with the paradox. The government programs, Medicare for seniors, Medicaid for low-income patients, pay hospitals less than what care actually costs to deliver. On Medicare, hospitals run something like a -13% margin, and those two programs cover a big majority of hospital patients. If a business loses money on most of its customers, it should collapse. Hospitals don't, which means somewhere in the building, a smaller group of patients is not just covering their own care, they're covering everyone else's losses too. Find that group, and you've found how a hospital makes money. So let's answer it like an operator. How does a hospital make money when it loses money on so many of its patients? The whole system runs on one hidden engine, a cross-subsidy, plus a handful of high-margin services and a few clever financial moves. One note before we start, this is how hospital finance works, not medical or financial advice. Let's follow the money. Here is the engine, in one number. For the exact same service, a commercial insurer, the kind you get through a job, pays a hospital about 254% of what Medicare pays, 2.5 times. That gap is not a rounding error, it's the entire business model. The commercially insured patient is the one carrying the building. Everyone with an employer plan is quietly paying a premium that covers not just their own care, but the losses the hospital takes on its Medicare and Medicaid patients down the hall. Look at the other side of that gap by the hospital's own accounting. For every dollar it costs a hospital to treat a Medicare patient, it reports getting back only about 84 cents. Medicaid, about 88. That's a slightly different yardstick than the -13% margin. Different accounting, same conclusion. Both land below break-even. Now, a fair caveat economists insist on. Part of the reason those numbers look so bad is that hospitals with plenty of rich commercial revenue let their costs drift up. The low Medicare margin isn't purely the government underpaying. But the direction is real. On government patients, the hospital is underwater, and it needs someone to bail it out. So here's the engine on one card. Commercial patients are paid well above cost. Government patients are paid below it. And the surplus on the first group is what covers the loss on the second, inside the very same hospital. That single mechanism explains why two identical hospitals can have opposite fates. The one in an affluent suburb, full of well-insured patients, prints money. The one in a poor neighborhood, full of Medicaid patients, quietly bleeds, not because it's worse run, but because of who walks through the door. In hospital finance, your payer mix isn't a detail, it's destiny. You can see the cross-subsidy in the raw split. Private insurance is about 37% of hospital revenue, Medicare 25%, Medicaid 19%. But here's the tell. Government programs cover an even larger share of the actual patients than of the dollars. That gap, big share of patients, smaller share of money, is the cross-subsidy made visible. A minority of well-insured patients supplies a disproportionate slice of the revenue that keeps the whole place solvent. Now, the cross-subsidy explains who pays. The next question is where inside the hospital the actual profit is made, because it is very much not spread evenly. Profit inside a hospital hides in 4 places, and the emergency room and general wards usually aren't among them. First, a handful of surgical service lines, heart, orthopedics, cancer, throw off almost all the margin. Second, the profit center has physically moved out of the inpatient bed into outpatient. Same-day surgery, imaging, infusions. Third, a federal drug discount program called 340B, created to help safety net hospitals stretch scarce resources, lets qualifying hospitals buy certain drugs cheap and bill insurers full price, keeping the spread. Whether that money reaches poor patients is the running controversy. And fourth, in good years, Wall Street. Big hospitals sit on billions in reserves, and investment income can dwarf what they earn treating patients. Let's put numbers on the strangest ones. Take the operating room. In one national study of Medicare cases, a single coronary bypass, heart bypass surgery, threw off roughly $10,000 of what's called contribution margin per case. That's the revenue left over after the variable cost of the case, before overhead. Not pure profit, but the money that helps cover everything else. Across Medicare volume, that added up to about $1.5 billion a year, and commercial cases can pay even more. Researchers literally call cardiac surgery the moneymaker. Orthopedics, hip and knee replacements, spine, is the other pillar. A hospital's reputation is built on saving lives in the ER, but its budget is built on a few scheduled, well-reimbursed surgeries. That's why hospitals compete so fiercely for heart and orthopedic programs. Here's the most quietly lucrative move of all, and you may have paid it. When a hospital buys a doctor's office, it can rebill the exact same visit at hospital rates, tacking on a facility fee for the building. In one documented case, a woman had gotten a joint injection from the same doctor for years at about $30 a visit. After the hospital took over the clinic, nothing about the care changed. The bill jumped to $1,394, including a $1,200 facility fee for an operating room that didn't exist. Medicare pays a hospital far more than a doctor's office for the identical service. That price difference is a big reason hospitals have been buying up practices everywhere. A thread we'll pull next. And in a strong market, the biggest non-profit hospitals make more money on Wall Street than on medicine. In 2021, Kaiser Permanente reported $8.1 billion in net income, but only about $600 million of that came from actually running its hospitals, a razor-thin margin. Roughly 93% of the profit came from investment gains on its enormous reserves. The next year, when markets fell, that reversed into billions in losses. The lesson: a big hospital is partly a hospital and partly an investment fund. And which one drives the bottom line depends on the stock market, not the patients. Now the honest caveat, because this is where the story is often overstated. That commercial patients cross-subsidize government ones. That's real and undisputed. But the stronger claim you'll hear from the industry, that when Medicare cuts its rates, hospitals are forced to raise commercial prices dollar for dollar, is not well supported. The economics literature largely rejects it. One landmark study found that when Medicare cut payments, private prices actually fell, not rose. The reason high commercial prices exist isn't mainly that the government underpays. It's that big hospitals have the market power to charge those prices, which brings us to the last piece. Because if high commercial prices come from bargaining power, then size is money. A hospital with no nearby competitor charges about 12% more than one, with several rivals. And consolidation has made concentration the norm. In nearly half of American metro areas, just one or two hospital systems now dominate the inpatient market. That's the deepest way a hospital makes money, not by treating patients better, but by getting big enough that insurers have little choice but to include it, close to the price it names. Merge with the competition, and your negotiating leverage and your prices tend to go up. And the same engine, run in reverse, explains the tragedy at the edges. Where there aren't enough commercially insured patients to cross-subsidize the losses, rural towns, poor neighborhoods, the model simply fails. Since 2010, more than 150 rural hospitals have closed or stopped offering inpatient care. It's not that those hospitals were badly run. It's that the entire business model of an American hospital depends on having enough well-insured patients to carry everyone else. And some communities just don't have them. The cross-subsidy is a lifeline and a fault line at the same time. So put it together. A hospital loses money on most of its patients and makes it all back on a smaller group of commercially insured ones. The cross-subsidy at the heart of it all. Within that, a few surgical lines and the shift to outpatient carry the real margin, with facility fees, drug discount programs, and investment income stacked on top. And the ultimate lever is market power. The bigger a system gets, the higher the price it can name. None of this makes hospitals villains. Most are genuinely trying to fund a mission. But it explains almost everything you find confusing about a hospital bill. It was never really about the cost of your care. It was about who's paying and how much leverage everyone has. So the next time you see a hospital break ground on a gleaming new tower while pleading poverty on Medicare, you'll understand the machine underneath. A cross-subsidy, a few high-margin services, and a lot of market power. Next time, we pull on the strangest thread of all. How the hospitals that pay no taxes, calling themselves non-profits, ended up among the richest institutions in town. For more on how the system really works, visit ShaneWelter.com. I'll see you in the next one.